going to talk to us about those patients that require ventilation. And these patients do consume a large number of bed days within the hospital, and he's embarking on a project to try and move some of these patients into a more appropriate setting, whether it's a community hospital, whether it's into their own home or a supportive housing unit, and has really been leading the province, I'd say, in terms of some of the work that Jim is doing.
Thank you very much, Mike. I'm as I said, Dr. David Leasa, and Cathy Mawdsley will also be here. She's done this to me before. She walks in later. We're going to try to do a tag team in terms of the information here to present within our time. I'm a respirologist and also work out of the ICU at University Hospital, and Cathy is a clinical nurse specialist who works out of the critical care unit at University Hospital. And so we've been very thankful to this group for supporting this project that we're trying to, again, move forward, and let's give you some details with respect to that. And very quickly, I just want to define that long-term mechanical ventilation, and we want to try to give you an idea of what these patients are like and what these individuals are like with regards to this complex technology. But long-term mechanical ventilation has been defined by a number of groups, probably the more recent one by the Ministry of Health from a task force that, in fact, Cathy and I were involved with for a number of years ago, that defined mechanical ventilation in terms of long-term as requiring this type of support for more than 6 hours a day for more than 21 days, and not requiring really the additional resources that one would need within a critical care unit. And so many of these patients are obviously are stable enough to move to other environments. So that's the group that we're trying to look at. And just to give you an idea of the three big areas that we think about, and I'll talk a bit more about this in another slide, is that we talk about patients prolonged mechanical ventilation, and these are patients that end up in our ICUs for more than 3 weeks on generally invasive mechanical ventilation through a tracheostomy. You'll hear that term, and generally their care is within some segment or some area of the ICU. Long-term ventilation is more likely a term that now extends to those patients that will require this for the rest of their life, and so they end up needing either invasive or non-invasive supportive breathing, and non-invasive supportive breathing may be through a facial interface of some type. And then there's another larger population that we have to think about as well, and those patients at risk. These are patients that are out in communities. A lot of these patients have neuromuscular diseases that with time, if we don't intervene, they will end up in our intensive care unit one way or another. And so we want to try to intervene early on and particularly apply what we call non-invasive ventilatory support. And then we also have to now start thinking about kids that are growing up on this type of technology, and as you know, but when they reach the age of 18, a lot of the resources that they have in place suddenly disappear when they're asked to transition to the adult environment. So just to give you a flair of some of that, if you're not familiar, these are just non-invasive ventilators. They're shoebox machines. The technology has really changed over the last number of years. These aren't simple machines that one would use to support the airway with obstructive sleep apnea. These are actually ventilators. These machines breathe for patients. They assist every breath. And there's different interfaces that patients can go on with respect to that, and trying to ensure a comfortable fit and obviously to ensure good compliance. There's also invasive ventilators. Again, these are larger machines. Patients may require these for 24 hours a day, not just nocturnally. Obviously this technology has to be taught to these individuals. This is just an example of an individual coming into a clinic for a tracheostomy tube change dependent on 24-hour-a-day invasive ventilatory support at home. You can imagine the equipment on the back of his chair. I sometimes tease our medical residents that there's probably more resuscitation equipment on the back of this chair than there is on the 4th floor inpatient service in terms of what's necessary. And obviously this type of equipment has to be used appropriately and knowledgeably by family members. It's changing as well in terms of, here's an individual with Duchenne's muscular dystrophy who has non-invasive support at nighttime, doesn't have a tracheostomy, which is good, but has non-invasive support at nighttime to support breathing, and then during the day has an apparatus for mouthpiece ventilation, again to support their breathing at demand when they're up in their wheelchair. And the technology is even getting more sophisticated. These are just 2 recent ventilators for home that can do both non-invasive and invasive ventilation. We're waiting for decisions from the ventilator equipment pool here in Ontario in terms of what their decisions are going to be with respect to that. And we're very fortunate in Ontario that we have equipment that can be provided to these patients. And this is through the ventilator equipment pool in Kingston. And so that we can submit for this equipment, and the equipment can certainly be funded for them. Now, I want to spend a little bit of time with this slide, just to sort of give you an idea of our population of patients and what we're looking at with this project. Because we're looking at patients who require any type of long-term ventilatory support. And if you look on the left side here, it's more invasive. On the right side, it's more non-invasive. And in the center, I'll talk a little bit about what needs to be done in terms of following these patients on a regular basis. But here we want to identify patients early on in ICU, of those patients that we can transition to other environments. We don't want to keep them in our ICU bed. We would like to transition them to other care environments to move their care forward. Now, we're ending up with a larger population of patients these days that we maybe best describe as the chronically critically ill. These are patients that end up in our ICUs for more than 3 weeks on a ventilator, usually with a tracheostomy. And they many times have significant comorbid problems as well. And we never know many times where these patients are going to end up. Some of these patients end up dying in our ICUs. Some of these patients are successfully weaned from mechanical ventilation and go to wards and end up dying. Some of them are successful in terms of their care and are able to be discharged home alive. When we follow these patients prospectively, unfortunately many of them a year down the road may still be alive, or fortunately they still may be alive, 50% still be alive, but when you look at their functional abilities, that's maybe only 10% of them really have independent lifestyles and are fully independent. So it's a population of patients that we're trying to look at as well, and trying to identify early on those patients that we can focus the care on, and identify that we can move to other environments. So we're looking at patients that we can transition elsewhere on invasive ventilatory support. This may be to the home environment. It's also with partnerships that we've created through Parkwood in terms of having custodial care of patients who can't go to other environments, and trying to have their care appropriately provided. On the other side here, we're also looking at patients that come from clinics. Many of them are from neuromuscular disease clinics, ALS clinics. These are patients that are obviously, we want to identify them early on because they are failing in terms of their breathing. And we want to identify them appropriately and place them on non-invasive technology. And I'll talk a little bit about that in a second. We're even looking at trying to now do this as an outpatient process in terms of when we identify them, we want to give them the training and the equipment in an outpatient setting rather than bringing them into a hospital and tying up a hospital bed for that purpose. And then the last part here is the issue with regards to the kids that are coming up from pediatrics on non-invasive or invasive ventilatory support. And again, we need to look at a way to ensure that their care continues. In the center, you can see that what's necessary here is an outpatient interprofessional care process for follow-up, because you just can't put these patients out into the communities and expect that they're going to flourish. They obviously need to have considerable follow-up, troubleshooting. You need to provide them with proactive care to deal with potential problems that will exist. Now, just to give you an idea of the at-risk population that we're talking about here in terms of those from the neuromuscular side, we're putting in, it's not just putting in support for their inability to adequately breathe with what we call a non-invasive ventilator, but it also means we have to look at other aspects of their care. They have weakened expiratory muscles as well, so they don't cough and clear secretions well. So we have to pay attention to that in terms of doing various maneuvers, or what we call cough assist activities. Physiotherapy needs to be very much involved. They're at significant risk in terms of infection, so vaccination is very key. They need to have a very clear acute care practice plan. What happens when they get a respiratory tract infection, what to do, who to call, how to deal with those problems, because the last thing you want this patient to do is to end up, again, in your ICU, now invasively ventilated. You want to try to prevent that. Many of them have problems with swallowing, so it's an additive problem in terms of issues. And then all these patients, there has to be an ongoing assessment of their end-of-life and resuscitation wishes. We need to make sure that that's clear and well documented. So our background of our project is that we want to look at individuals who require long-term mechanical ventilation and those at risk of becoming so that we can have them experience improved quality of life and good access to quality, safe, and appropriate care. At the same time, we want to try to have a seamless care coordination of various professionals that these individuals need, so that it can be timely, and it also can transition across various potential care environments, even starting from the ICU and going out to the communities. And this is our diagram that we look at, trying to get a picture of that delivery system that's necessary, because this is really chronic care. And Cathy and I have had to learn this from ICU. We've come from ICU. We've come from that silo. We realized that we need to extend ourselves outside the walls of the ICU into the communities and to try to move these patients forward in terms of their care, because there has been a void over the years in this area. So to do it properly, we obviously have to have knowledgeable individuals as part of our team. We need to have community partners that are appropriately resourced in the community. And we need to have patients and families that are empowered and knowledgeable so that they can look after the problems that will exist with regards to that care. Between all these groups, there needs to be very productive interactions. There needs to be productive communications. There needs to be clear communication lines, as you very much realize. And I think part of that, and it's very, very important here as well, is that I think key is having a very centralized information technology system so that it allows us to communicate clearly, that extends from the hospitals into the community. And I'm sure that you're well aware of that issue. The issues that follow here is that I've just listed a few of the areas that we always have to put concerns in, is that we want to make sure we put the right patient on invasive or non-invasive ventilation in the community. It's a very important piece of our puzzle. We need to have clear criteria for that. We want to make sure there's appropriate resources, particularly out in the community. Respiratory care resources are very important in community for these individuals that presently don't clearly exist. We need to have the best decision support, and that is being developed across the country, and I'll present a little bit more about that in terms of various guidelines. These patients many times need case management, individualized case management, because they do have complex problems, hence you need a lot of individuals in terms of that interprofessional care. Clearly, the education side of it is important. That has to be well developed, not only for the community partners, but also for the patients and their families, so that they're well informed and able to look after this equipment. A big part is just navigating through a maze of healthcare services. And again, I think that part of our system as well is to try to have one number to call, one navigator to assist these individuals. for this complex care. And as I mentioned, the follow-up is paramount in their ongoing care. So these were our goals and objectives. And I think I've really talked about these individually, but we want a regional interprofessional system that optimizes delivery of care to these individuals. We want to clarify the resources, the roles, the responsibilities that's necessary within this interprofessional care system. We want to make sure that there's clear communication strategies amongst the various providers and environments. We want to make sure that there's a good educational strategy in place for all, and we want to make sure that there's proper tools that can be used for various providers so that the practice can be standardized, again, across our region. We know there's lots of constraints, and these are certainly constraints that are very familiar with yourselves that I don't need to, I think, go into. But we certainly know that overstressed primary care. Some patients I follow on invasive mechanical ventilation don't even have family doctors. And so you can understand the complexity and with respect to that. So we talked about a few of these aspects here that there clearly are constraints, as I've shown on this slide. Now, within Canada, there are a number of good developments recently. The Canadian Thoracic Society is about to publish some guidelines on home mechanical ventilation, which is certainly very helpful. It's probably around a 180-page document. So this will certainly help us in Canada because there's a lot of heterogeneity across our country with respect to the care of these individuals and also access to the technology that's required. West Park Hospital in Toronto is known as a long-term ventilation center of excellence, and so they have been developing certain educational tools that I think are very important, and some of those are on their website. We have, Cathy and I have been involved with a Canadian community of excellence now in long-term mechanical ventilation or prolonged ventilation. This is developing, really trying to get an idea of a registry across Canada of appropriate, of what we're doing across the country for these patients, who these patients are, the types of problems that they have in terms of diseases, what kind of resources they can access from a countrywide point of view, who are the interprofessional people that are leading the care. So this is something that is right now trying to be developed, which again I think will be a very valuable resource for the care of these individuals. And then lastly, I think your group has just recently seen this, that the College of Respiratory Therapists have developed a very good resource for education. And many of our RTs were participants in that process. So it's a good starting point for translating this care from an educational point of view to various providers and also to various families and patients. So with that said, I'm going to let Cathy do the harder part. She's going to talk about our activities to date to give you an idea of what we've been doing.
All right, thank you very much for your time. What I'd like to do is take the next 5 or 10 minutes and kind of take what Dave's talked about here and let you know what it means for us at the bedside. What was huge for us is when we received the funding from your group in terms of to pursue this project. And before that project, all I can describe what happened in the 10 or 15 years that we've worked with these patients is it was very much, we kind of jerry-rig a system for an N of 1 patient. We go out into the community, ask our CCAC, our GPs, our community RTs to go above and beyond for this N of 1. Because everyone, whether it's acute care or community side, wants the patient out of acute care and back in their home and back in the community. And after each patient we do have an N of 1, we're like, okay, we've got to sit down next week, we've got to pull things together, get tools standardized, get all the contacts listed out, and then you get bogged down in your critical care work, your community work, then the next patient comes. In a chart review that we did in 2008, patients who actually required long-term ventilation were consuming over a 2-year period about 400 bed days for us in the ICU. And these are patients that didn't need us. They wanted their home, they wanted their own bed, they wanted their friends to visit, and not the structure of an ICU where we have restricted visiting hours, there's infections in hospital, and the food is awful. So they don't want to be there. So what your money allowed us to do was actually hire a project leader. And this project leader that we had has an extensive background in process engineering, and that was fascinating for us. She basically referred to us as herding cats. And I don't know if you've ever seen that Super Bowl commercial back in 2004, 2005. And it shows this cowboy out on the field, and it shows this wrinkly, crackled face, and he's talking about herding, and we're thinking, you know, it's horses or cows. Well, it backdrops into these cats scattered all over, and that's kind of how she saw us. Each of us had a passion for one part of this patient population, but we had never had the time or somebody with the process experience to sit us down and say, how can we maintain good care, how can we get them back in the community, and how can we make sure we're using our resources well. So that was Colleen Keeler. So this is essentially the themes of what we've worked on, and I'm going to go through a couple slides that highlight more clinically what it means. So the project charter was developed, which you saw, and that's what enabled us to get the funding that we have basically to the end of June. A long-term ventilation intervention map was developed, and again I'll explain that later. Recommended actions, the chronic ventilation clinic Dr. Leasa talked about. But a key thing to jump off this slide here is what we've done in terms of partnerships for these patients. The work we've done with Parkwood over the last 2 years has been phenomenal in that when Dr. Leasa talked about the silos of critical care, our silos can be pretty thick, let alone within LHSC, let alone beyond. And we met a team that was just as passionate that we were about getting patients out of an ICU, on technology, into a complex continuing care. So a relationship is developed in that we've shortened how long it's taken to get from ICU to Parkwood. But as well, what's happened is when they run into what used to have been crisis for them before, we're able to triage over the line as ICU. And they're able to stay at Parkwood and not take an ICU bed. And we actually have feedback from Parkwood patients is they don't want to see us. Because what they lose is their bed, their TV, that sense of being a person. They now become a patient. They lose their routines, and what they come in is basically another patient in a 40-bed unit. You got to fit into our routines, and wake-up call is generally when shift change occurs, and you've got 40 nurses walking through the unit. So this is our Ltd Intervention Map, and this is specifically what Dr. Leasa talked about with the 2 different machines. So on paper, it may not look like a lot of patients. We may end up, especially those needing a tracheostomy and 24/7 invasive ventilation, we may only encounter 4 or 5 a year. But what's really important is they include a huge amount of bed days, and we want to make sure now what we're able to do with this whole process map that we've done is we're able to identify them early. Because if you look at, this is the group that we're actually targeting, we want to know who feeds into that group. Because as soon as we know who feeds into that group, we can identify them early, give them the right care at the right time, make sure they're not a false positive and that you're going to be on a ventilator for life, and guess what, they don't, and we find that out 2 months later and they're still in an ICU. So it's really important to know what the entry is, and in terms of the exit. So this is a very simple version. To give you a quick snapshot of the work Colleen has done for us, this is our process map, from our entry to the intervention to out. So for a straightforward, simple patient, there's 7 transition points, 7 decision points that need protocols, checklists, and a multidisciplinary team to come together to make a decision. And this is why without that process piece, our care was fragmented, and each day became, well, it's Friday, we can't make a decision until Monday, there's the weekend. There's 2 more bed days that get accrued on here. So for the simple patients, it may only be 7 transition points. For the more complex patients, it may be 14 transition points. And for each of these transition points, whether they're circles, boxes, or triangles, there's 10 or 11 processes beneath that. So again, while it's a small patient population, it consumes a huge amount of clinical resources and planning and community resources trying to move these patients through. So for each of these process points, we ended up with like 122 recommendations. And what I have, if you're interested, and I promise you it is not light reading, we have our project work plan here. I can leave a couple copies here, you're welcome to surf through it. Any questions, Dr. Leasa and I are happy to chat with you about. So I don't want to show you, I'm not showing you all 122, I promise. I'm just looking at some of the looks of the faces. So while Colleen helped us with the process piece, what we wanted to make sure is that the patient side of this came through, and that got into we needed to have a model of chronic care. And the reason is these are chronic care patients in an atypical way. They're in the most acute place in the healthcare system as in critical care, but they're chronic care, and those 2 concepts collide in the ICU and create friction. So we need to find a way that best supports the patient quality, getting them out of the unit, getting them into a place they want to be. And this is the chronic care model that we use, and we have the article again if you're interested. So it walks through 6 concepts of decision support, community resources, delivery system design, healthcare organization, self-management, and clinical information. So for each of those 14 transition points and each of those 10 processes within those 14 transition points, we had to look at these 6 things, because what we learned the hard way before we had this process piece done is we would do something out of the good of your heart. You got the patient where they wanted to be. So we had a young mom come through the unit in her 20s. She had a debilitating cerebellar and basilar stroke, had a young 4-year-old at home. So here she is. Think of when I was that age, like 20 years ago or whatever. The last thing I want to be in is an ICU where I don't have my family, I don't have my friends, and she's a young mom. And I think 10 or 12 years ago, we would have said, your life is here in the ICU. They live 3 hours away. What we now had the opportunity to say is, your life is, we're going to be able to get you home, but you've got to commit to us that this is going to be a process of weeks. You're going to have to come back to see us in the chronic vent clinic. This is not going to be easy. So this is where the teasing out of what do they want out of this. She wanted to be a mom. That was paramount. She didn't care if she was in a wheelchair. She didn't care if she had a right-sided deficit. She wanted to be, her goal was she wanted to go to school the first day Caden started kindergarten. And that was all the motivation we needed to make that system work. And we were able to do that. She's at home. Her mom is a primary caregiver. The community resources are less than ideal for her. And that's part of what we're trying to change with this project, is identify. She has been very gracious in giving feedback to us in terms of what's working, what's not, what's quality, what's not. And this is what this process is allowing us to do, is to identify that from a patient perspective and able to make recommendations to change that. So I'm just looking at time. I'm not going to walk through these in a huge amount of detail, but again, what I'd like to stress here is that what this process has done is breaking down silos. We just recently had a patient that we transferred out that came up from the US, and he was out of our, quote, traditional LHIN. So right away, we're now dealing with a CCAC and a different LHIN. And there aren't systems there. They've never encountered a patient who's been ventilated at night before. He was a complex patient. But as soon as you make that call, they're all willing to come to the table because they want him home, they want him out of ICU. They've got a committed family that's willing to support them, and everybody realizes that living with us is not the best place to live. And I can be quite upfront about that. We're not the friendliest place to live for years on end. So the community was able to do that. And so what we're going to use him is as a test case, is as these recommendations come out, is fly them by that LHIN, fly them by that CCAC group. Because they had never dealt with us before. They have feedback for us of what to make it better for the patient. And likewise, how can they help us recommendation-wise in terms of to make sure the system works better. The other piece here under recommended actions, and it touches into a bit of what Dr. Leasa talked about, is some of our patient population comes into kids that have been on ventilators since they were 2 or 3. And they're now 17 or 18 years old, and they're graduating to the adult system. And the clear feedback we get from them and the parents is, coming to the adult system, they grieve. Because pediatrics treats them so differently. In terms of CCAC hours, support in the school systems. They lose Thames Valley Children's Center at the age of 21. They come to adult land. There isn't the seating support, the PT support, the OT support. So this empower patients and families, that's one of the things we're learning from the pediatric area. And so when we start rolling this out in terms of our interprofessional education, it also applies to our caregivers we have out there as well. So we're in the midst of developing a website for patients and families. So whatever technology they have, they can access 24/7. I don't know about you, when you go to a specialist office or a GP office, you have your list of questions, you get information, you go home that night, you have a cup of tea, and you've got 5 more. And that's what we want to make sure, that we open up avenues for these patients and families, is once they leave us, they still have that conduit back in terms of if they have questions. Because the one thing we've learned is, if we leave them there with questions, they get stressed, they get anxious, and they seek emergency care, and they're right back in emerge, and they come right back to us. And this is what we're trying to avoid, is these patients and families. The analogy I use is, what we're trying to do is build a car, and they want to be in the driver's seat. They want that driver's seat so bad, because they know what trajectory or what journey they want, and we've got to make sure we have the right car. So our job is to make sure we give them Cadillac, probably on the leanest of budgets we can. But we want to make sure they can drive that car through this healthcare system, and I look at it as, we're like travel agents. How do we help them along the way? We give them advice, they design their trip ticket and away to go. But that's our philosophy, has to be now with these patients and families, is we've got to get them out because they're in the wrong place. And whether the better place is Parkwood in terms of complex continuing care, We have patients that are at Participation House here in the city, so more of a group home, and you'll see them throughout the city. They're at movies, they're at malls, they go to the Western Fair, or maybe the best thing for them is home. I'm just going to zip through for time. We have a bunch of checklists and screening tools we've developed, and essentially the message with the checklist and the screening tool is once we roll out and do our roadshow up to Owen Sound, to our partners in the LHIN, is everybody has these tools. So the right care and the triggers for screening can be done anywhere within this LHIN. It doesn't need the expertise of an academic center. And as well, what will go, this is the support by phone from us, but the roadshow will involve a face-to-face in terms of, this is why we want to screen early in the unit, make sure the intervention is right. So next steps, the next couple of months fall into some of those models under the chronic care model that we're using. In terms of decision support, from a staff side or from a caregiver side, we want to make sure they have the right decision support no matter where they are, whether it's CCAC, whether it's Parkwood, or whether it's us. So one of the things we're working on with Cerner is we're allowed to be a pilot for CCAC to have access to some of our documentation and some of our communication. Because sometimes what we have is patients showing up in our chronic vent clinic, and we have the patient family story, which is so important, but what's happened in that week before them coming to clinic, we don't have the healthcare provider piece on that, and that's either been left in the binder back at the home where it's usually kept. So that's part of the systems we want to design there. The brochures and websites we've talked about already, the chronic ventilation clinic we've talked about, the partnerships both within and with outside the LHIN. And last but not least, because this is a new venture for us from a process piece, is one of the things we want to produce out of this is an evaluation and a sustainability plan, so that we can come back to you with recommendations of the model is done, the education is done, the rollout's done without the LHIN, and this is what we see in terms of next steps. And that's it. Thank you for your attention. If you have any questions, I think we might have a couple minutes. But the floor's open.
Linda?
So thank you for that. I think it's an important project. Being one of those families, I was one of the first 30 years ago to bring a child home that needed many of these services, from an NG to a G-tube, ventilation, all that kind of stuff.
Yeah.
To date, don't need any of that. But anyway, regardless, I didn't see anything there where you talked about respite or respite for families.
Yes.
And the other piece on management of finances, which
Yes.
sometimes is quite overwhelming for
Yeah.
families. Is there an assessment tool for either of those things as well? I hear that the CCAC is involved, so I'm sure there might be some discussion around the respite piece with them.
Yes.
The other piece is in the more rural, remote areas, the access to equipment renewal. And pieces and components. It's very challenging. So I didn't see that in any of the assessment tools, but I'm having a feeling that you're already thinking about these things.
So we've already, we did I think 2 situations with Parkwood Complex Continuing Care. We brought patients in for respite. So it's what we do before we discharge from the unit, is outline respite options. So whether it's Parkwood, we've had some great creativity from CCAC that have been able to bunch CCAC hours to provide a weekend of respite for a family, and a weekend for them is like a God gift. And for us, it's like, well, it just flashes by in an instant. But you're right, it's challenging from a resource piece, but what we've found is if CCAC can find the community nurses, they'll do it. What I didn't get a chance to touch on here, and part of the healthcare organization, is right now we're relying on one caregiver group to support these patients out in the community, and that's basically nursing when it comes to shift nursing and spot nursing in terms of daily checks. And we had a great experience with the Norfolk Oxford CCAC in that they couldn't find enough community nurses to support our shift nursing needs. And so we were quite aggressive, as critical care can be, is that you have an envelope of money for him, can we be creative? We didn't want more money, we just wanted to tackle that envelope differently. I was learning this language as we were going through it. And so we were able to make a case that the RT provider in the area would be paid for a series of visits that would come in just to bridge us over this hump we were working through with an acute chest infection. So that RT was key to keeping that patient longer at home and avoiding emerge activity in the Tilsonburg area. But that's some of the challenge we're finding is if there's enough nursing, it's one thing, but if there aren't enough nurses out there and there's still that pocket of money that we could we could use for that patient, it's that creative discussion you need to have. Can we put an RT or a different care provider in? And you're right, anywhere beyond probably like a city in terms of going out in the community.
It's difficult.
It's difficult to get resources in, and these families and patients are quite something, and it sounds like from your experience you've learned those skills as well.
And everything happens Friday night when everybody else
Yeah.
has gone home. The second part of the organization, so you talked a little bit about having access to professionals if the family is in need of some guidance on a
Yeah.
particular issue. Does that carry over 7 days a week, 24/7?
This is one of the things we're looking at in the sense of, we do it informally right now, our RT department at University Hospital, they'll get calls from people in the community, from patients and families, saying the high pressure alarm's going off, what do I do?
Mm-hmm.
So this is the beauty of Power Chart, is they're able to go in, look at the last summary, the last thing from clinic, troubleshoot, and then if it goes kind of beyond a scope and comfort, you're gonna have to come into emerge, and then they'll meet them in emerge. But that is our goal, in the sense of there's some creative things we're looking at in terms of different teams we could use for that. But you're right, everything happens Friday night or Saturday morning at 4. You
Always
run into
does.
some kind of failure, yeah.
Always says, thank you for the great work. I mean, this is an important project, certainly. You're right, the setting is better when we have choices in our lives, so
Yeah.
that's great. Thank you. Look for the update.
Any other questions?
I'm interested in the bullet under known constraints, that financing is dysfunctional.
Yeah.
And I'm interested from your perspective, how could it be functional? What needs to change to make it functional?
Well, I think it's one of the biggest problems, I think we mentioned, is respiratory care services in the community. These patients certainly do need that, and respiratory therapists need to be funded in the communities for that practice. They're funded now for oxygen, but certainly not for activities such as being on a ventilator. We need to have their ears and eyes, and they feed back very important information to us. And we need to mature that type of communication so that they know, there's somebody out there that can provide you with information and quick feedback back to them as well for troubleshooting. So that would be certainly the one aspect of it.
Yeah.
Cathy, you want to?
Probably the story you've heard already, and that the nursing hours are insufficient, and part of the challenge of getting nurses into the community is the pay grade between community nursing and acute care nursing is huge. And we have some of our ICU nurses that do community nursing because they like that piece of it. And that's often a big disengagement for them, because I look at it as in critical care, especially here in London. You've got 24-hour doc support, you've got a colleague just a bedside away that can help you troubleshoot, and there you are on a Saturday night at 4 in the morning getting a call, and you're on your own. You can't get hold of a GP. Sometimes for the community nursing, to send them to emerge is seen as a failure. That's kind of a stereotype at times for them, where we look at it as, if you've gone through the list, that's the best place to go. And so part of it is a wage thing, part of it is a model thing in terms of they're so tightly run and it's so targeted that a nurse could go in to look at a GJ tube but not be trained for trach and suctioning, so can't answer any of the suctioning questions. So a different nurse would have to go. So the CCACs we've been working with have been fabulous at trying to band-aid and make things work, but it's just an issue of not enough nurses that are skilled out there.
I just have one more question, Joe. You talked about process engineering.
Yeah.
And Colleen
Keeler,
Keeler
yeah.
came in and did something for you. Is Colleen Keeler, or folks like her in process engineering, only specific to RT? Or are they simply process engineering that could come into this system and look at? Because it sounded to me like you were struggling doing and didn't really have time to step back and see, okay, what is it we're doing and how should we be doing it? And she did that for you.
Yeah, she has no clinical background, and as she says, excuse the crassness of it, but she says, I'm the dumb one in the room because I don't know anything clinically. And when we worked with her last summer to develop that process map, she'd ask questions and we'd kind of look at each other like, I hadn't really thought of that. And
but is that happening in the system? You're aware of it in this area. Is that happening through the system? There's process engineering everywhere?
there's a department, Leasa LHIN, that I know about in terms of quality patient safety and project management. So Colleen comes from that group. Steve Elson is the project manager we had, a project leader from the very beginning. And right now I'm involved in a team on central line infections that they've been looking at process stuff. So for us, I think the process mapping and doing the whole failure modes, the failure modes effect, the FEMA thing with that, and the control charts, while it was painstaking, it really helps you build a system that as a clinician, you don't get a lot of that background when you go through your education. So I found that she's the success factor so far.
She put it in a box for us to work towards, and she gave us those tools that we really did need. Because, you know, as I said, we're very busy clinicians working mainly from the ICU, and this is extending outside, well outside the ICU. Mandate and resources, so we needed that type of person.
Yeah, I'm the critical care lead for Southwest, and I want to congratulate Cathy and David the amount of work they've done on this.
Sorry, I can't hear you.
The amount of work they've done on this project, I don't hear that very often, that they can't hear me. The work they've done on this project, I've been impressed, and I don't say that very often. If you say I said that, I'll deny it. But this is really a development of a model that we need, not only the Southwest LHIN, but across the province. The challenge here is to take this across the province. And Mike and I have discussed ways of doing that, and I think the most obvious way is through the critical care strategy, of which I sit on that committee. So I think we need to take this forward to them and work collaboratively with the experts in East Park and also in Ottawa. But I think this has been a tremendous project. Couldn't have gotten off the ground without your support.
Yeah, thank you.
We've went to a number of branding agencies for this and have come out of it frustrated because there are many projects that need to be done. But this is one that's very important, and without your support this couldn't have been done. But it's been good, but I think the challenge now is to take this across the province.
Maybe you have one final question?
Yeah, I have one final question. Just coming back to the partners who are at the table, going back a few slides. I know in some of our other groups there's a provincial body, and I don't know whether assistive devices is similar to the one that manages the equipment here. Are they at the table? Are they part of this decision-making process about how to do this better?
They're at the table with regards to the equipment.
Okay.
So the ventilator equipment pool is under the domain of the assistive devices program.
Okay.
So yes, for the equipment. What we don't have is a clear province-wide process for looking after all these patients. The best report was done a number of years ago. In fact, there were 2 reports with task force that were produced by the Ministry of Health. Cathy and I were participants in those. One got published, one didn't. So if you go on the Ministry of Health's website, you'll certainly see the details with respect to that. And a lot of these things were put forth but never really came to fruition. That was the problem. It really came initially also from the critical care secretariat, and so I think they started to realize that they may be beyond the areas of critical care and now starting to extend into community and a lot of other issues.
You raise a good point.
I'd just like to see an advance in how do we help.
I think once we make that next step to make this a provincial-wide project, then I think we need consultation. I think we need collaboration with all those various partners. Medical assist devices is only one.
Yes, and I just didn't see it up there, so I'm just asking.
Absolutely.
I think it's important that all those partners are at the table, and I guess, Michael, just coming back to you as this starts to unfold, making sure that they have the tools necessary in order to advance that agenda. So I look for your leadership on that, but certainly I can see this expanding, as you say, as a pilot for the entire province. So good work, and look forward to seeing that.
So just one summary comment. Mike did a good job of summarizing how this connects provincially, but I think it's very important that we look at the benefits that are coming from this and how it fits into the bigger picture. So ALC numbers are going to be driven down. Patients are going to move more seamlessly through the system, so that connection between from ICU to community is a big jump, and they're doing that now with structure in place. Our funding allow them to do that. And I think it's important also to realize that this was a LHIN-enabled project, but it wasn't necessarily LHIN staff that were out there doing the work. It was our health service providers showing leadership, and to have 2 physicians and a nurse practitioner heavily involved in this, moving it along, I think that's how the LHIN can be successful in moving these initiatives forward. And this is, one component of this large healthcare system, but it's making a significant impact for the lives of those patients that need ventilation.
got to keep in mind, these patients are few in numbers, but they consume horrendous number of ICU bed days. Yesterday, we canceled a pump, bypass, because we didn't have enough beds. So that's what it translates into. It's huge. And these patients need to get out back home, and that's what this project is all about.
Right now, we asked it on our equipment pool to kind of give us some idea in terms of the active clients out there. And there appears to be about 180 active clients. So it's not a, it is a significant number of patients. And again, the numbers are going up, particularly with respect to non-invasive ventilatory support.
Thanks to all three of you for taking the time for obviously a very interesting and presentation. We're looking forward to hearing how this work progresses, and on the provincial scale, certainly as time moves on as well. The idea of doctors being considered as herding cats doesn't give me great comfort, but having said that, it's obviously the work you're doing is very important. As you say, maybe not to a lot of people, but to the people it is, it's hugely important and very time consuming. So thanks again for taking time out of your busy schedule to come and talk to us today.
Thank you.
Do we need to take 5 minutes?